a big pleasure and also honor to introduce Professor Martin Cowie from the Imperial College in London, UK. And he's a very famous heart failure specialist and also primary investigator of the SURF-HF study. I'm sure we will hear also some data out of this study published in the New England several weeks or months ago. Please.
Thank you very much. It's an enormous pleasure to come to Switzerland and talk about sleep-disordered breathing. I've worked with a lot of different people, both pulmonologists and cardiologists interested in here, and this used to be the response amongst cardiologists when you talked about sleep apnea. Well, this is no longer the case because actually it's a very interesting area, and recent evidence, some of which I'll show you, has really challenged our understanding of the physiology and very much picking up the questions that the chairs have been asking. What's the evidence for therapeutic benefit? What's the therapeutic rationale? We know the physiology, but does it translate into benefit? So there are many key questions now that we're asking ourselves, and there will be several other large randomized trials published in the next year or two that will also add to the discussion. It's also very much easier, as Raphael said, to identify sleep-disordered breathing. So the problem is not finding the abnormal physiology, nor is it really treating the abnormal physiology. We have good ways of doing that. The big question is, how does this translate, or does it translate, into benefit for the patient? And what does that benefit look like? Is it purely symptomatic? Remembering that sleep-disordered breathing originated in obese, obstructive sleep apnea patients who fell asleep and killed themselves and others in road traffic accidents. That's where it started, and then the different therapies moved forward. But now what is a therapeutic imperative, particularly in patients who are not sleepy during the day? And as you've heard already, in the heart failure phenotype, irrespective of reduced ejection fraction or preserved or this ridiculous new concept of mid-ref, a tiny range in the middle, I'll just say that again, the ridiculous concept of mid-ref in the most recent guidelines, you can see that Cheyne-Stokes respiration, central sleep apnea, becomes more common as the heart failure syndrome deteriorates. You can see it here. Obstructive sleep apnea is very common in the general heart failure population, but Cheyne-Stokes then predominates in the more severe. But as I've said, what is the rationale and what's the evidence that actually going in and starting therapy, we are trying to persuade a patient to stick with this for the rest of their life potentially, what's the evidence that it makes a difference? Well, let me just focus on central sleep apnea. So a very abnormal physiology. It's been recognized for hundreds of years, if not thousands, and it can be well described by various different diagnostic tests and very common in the heart failure population. So some 10, 15 years ago in Canada, Doug Bradley and John Flores and others set up a trial of CPAP therapy for Cheyne-Stokes respiration. This was the world's first reasonable size randomized trial, trying to show benefit. You can change the physiology, it looks like a marker of risk, surely you can improve the outcome for the study. Now it ran into problems, one of which was recruitment, one was a low event rate, and initially the curve's going in the wrong direction, but for a variety of reasons that study was stopped early when it had only randomized 258 patients. This was still the largest trial in this area by a long way, however. And what they showed was changes in ejection fraction. They seemed to be going in the right direction. Plasma BNP also. There seemed to be improvement in sleepiness as well. But if you look at the harder cardiovascular endpoints, and this is survival free of transplant, there was no evidence of an effect, p equals 0.54. But you might have argued that it was an underpowered study, had run into several difficulties. And of course, as we all do as trialists, we look at our data again, can't quite believe what it's showing us. So here's a post-hoc analysis saying, okay, let's take patients who not only stuck with CPAP, but the CPAP actually controlled the central sleep apnea very well. So you see the top line there. For those patients that were randomized and continued with therapy and were highly adherent to therapy, and it controlled the central sleep apnea, because remember, CPAP's not terribly good at doing that compared to ASV, those patients had very low event rates. So in this post-hoc analysis suggested that perhaps if you could control the Cheyne-Stokes type respiration, that you would get a much better outcome. So as I said, new modalities and new algorithms, ASV, different from CPAP in that the pressure is varied and there's a backup rate as well, and averages out the respiration in a very, very effective way of normalizing central sleep apnea, and particularly Cheyne-Stokes. So ASV, lots of nice physiological experiments that you would actually control the abnormal physiology much better. Patients found it slightly easier to comply with therapy as well. The experience was slightly better for them. So we thought, let's take that post-hoc CANPAP. We've got all of the physiology, we've got all of the risk things, everything's going the right direction. Let's take a better way of treating it and demonstrate it in a nice, large-size, randomized trial that will convince our colleagues in the cardiac world. So we started SERVE-HF, and this was 8 years of work, many, many centres, both cardiac and respiratory, working together across the world, and sponsored by ResMed. And I have to say thank you for them for bearing with all of this, spending a lot of money in supporting it, and taking the results as they were. So 91 centres randomised. It wasn't sham, as you can imagine, too difficult to do. And it was just a question of getting optimal medical therapy and comparing it with optimal medical therapy plus ASV. We started the patients in hospital, we titrated it, we saw what their compliance was like long term, we tried to keep them in the study as long as possible. Very simple inclusion criteria: adults with systolic heart failure. We took NYHA class 3 or 4, or if they were milder, we wanted evidence of a hospitalization within the past 2 years, but that was largely to keep the event rate up, otherwise it became unfeasibly long and expensive a trial. We wanted predominantly central sleep apnea, and they had to have 15 or above, but in actual fact, most of the patients were very much higher than that. So we have a very clear phenotype: systolic heart failure, low ejection fraction, and good-going central sleep apnea. So we randomized eventually 1,325 patients into the trial. And this is what you spend $60 million doing, this slide. You're supposed to gasp and say, oh my God, that's amazing. It's not so amazing when you look at it. You can see the primary endpoint was neutral. Despite effectively getting the central sleep apnea way down, the AHI goes from high 30s down to maybe 5 or 6 in the vast majority of these patients. So the respiratory physiology is much better, but it didn't translate in terms of time to all-cause death, life-saving cardiovascular interventions, or unplanned hospitalization for worsening heart failure. Numerically, you actually had more of those events in the ASV arm. Looking at our pre-specified subgroup analysis, and this is all in the New England Journal paper from last September, what was very interesting, and I'll develop the theme a little bit during my talk, was if you looked at the proportion of patients, or the proportion of Cheyne-Stokes respiration as opposed to other forms of central sleep apnea, you can see that those that had very little Cheyne-Stokes actually, if anything, seem to get some benefit. But if you had 20% or more of your episodes being Cheyne-Stokes in pattern, you actually seem to have harm. And this was highly unlikely to be due to chance, although it is a subgroup analysis, but an interesting suggestion that something's going on that's worth exploring. What was very alarming and led to a safety notice for ASV technology in systolic heart failure and central sleep apnea was this. This is just counting bodies in the trials. There's no debate about this. They were either dead or alive at the end. And you can see the hazard ratio, the wrong direction, 28% increase in mortality applying with ASV. The effect appears and increases over time. That's the p-value. When you drill down to cardiovascular death, which is a majority of deaths for heart failure patients, you can see that the toxic sign is even stronger. The hazard ratio is 34% increase in cardiovascular death throughout the trial. So we are correcting the physiology, but we're not pushing it in a direction that looks very reassuring for our patients. Looking at subgroup analysis, and as you can imagine, this was a complete surprise to all of the investigators. So we looked very carefully at all of this, and it seemed to be across the board. But one thing we did note, and I'll come back to this, was that those that had particularly damaged ventricles, so an ejection fraction below 30%, you can see that the hazard was actually really quite substantial in that group of patients. This is the post-hoc analysis where we try to understand what was the mechanism of increased death for these patients. Was it related to pump failure deaths, or was it something else? And in fact, there was no real increase in heart failure hospitalizations. There was no increase in heart failure deaths per se, but this is looking at patients who had no hospitalization before they died. So presumably were feeling well, there was no signs of decompensation, and suddenly died. And you can see these curves separate in an alarming fashion right from the start of the study. And if you look at the hazard ratio, so this is a proxy for sudden death, and we're looking at it in much more detail now, and we'll hopefully publish in the next few weeks or months. You can see the hazard ratio is almost a threefold increase in the risk of sudden death in these patients by controlling the central sleep apnea. And it's not yet published, but I can tell you, as long as you promise to tell nobody, that when you look at the low ejection fraction patients, less than 30%, and those that didn't have a defibrillator, the hazard ratio is above 5 point something. So a 5-fold increased risk in sudden death in patients if you get rid of their Cheyne-Stokes respiration. So that is telling us something very important. You very rarely see such high hazard ratios in studies. And it's not because we didn't have enough events to analyze and we're going through all of this desperately trying to find things. This jumps out at you, and however you cut it, it doesn't disappear. Look in this trial, 8 times more events than CANPAP had. We had 425 deaths in total, and we had lots of hospitalizations. So we have lots of data to look at, and a very consistent theme when we do that. So just to flag up to you, they're not yet published, but a lot of these are now submitted or just about to be submitted. We did a very careful sub-study, hoping, of course, that we could demonstrate why the patients were doing better. But now, of course, we've gone back to them to try and demonstrate why they did so badly by doing it. But in the MRI studies, the biomarker studies, absolutely no evidence that the ventricular shape or function or the peptides change at all with this therapy. It's not as if you're blowing the ventricle up or that you're causing great strain on it in that sense. We couldn't see any change or any difference between the ASV and controls in that. The multi-state modeling, I've told you the kind of headline result from that in terms of the increased risk of sudden death. And then the on-treatment analysis does not make this effect go away, come up with very similar estimates for that. We will also have some ICD data analysis, although not perfect. We didn't design the study to have great detail on that, and we don't have the data for most of the patients who died with an ICD because they weren't interrogated after death. We will also have much more detailed PSG and PG data, which I think will be very interesting, and lots of other things. So not quite finished, but the interim conclusions from the study were that you cannot claim that finding the central sleep apnea and going in and improving it, so-called, by improving the physiology or the overnight sleep study with this translates into hard benefit for your patient. It does not. And in fact, for this particular phenotype with low ejection fraction heart failure, it actually increases mortality, raising the question of maybe Cheyne-Stokes is at least partially adaptive. A marker of risk, yes, in a sick patient, but getting rid of it makes the patient even sicker. And it seems to be an arrhythmic mechanism of death rather than something more functional. But please don't extrapolate to HFpEF. We don't know what goes on in that group of patients, nor acute heart failure. Our patients were chronic heart failure patients, distanced from hospitalization, and we had very little obstructive sleep apnea in our study. So that, of course, remains open to question. And about 2-3 years ago, Matt Naughton from Down Under wrote an editorial, which a lot of people kind of smiled at and thought how interesting, but moved on. But many people are coming back to, suggesting there's many things about cyclical hyperventilation that might be protective for a damaged myocardium and patient with heart failure. Some of those relate to the autonomic nervous system, as I've highlighted there, or electrolytes, intracellular electrolytes, but there are also some respiratory oxygen levels and reservoir and other issues, resting respiratory muscles during the apnea period, for example, that might actually be helpful. And bear in mind that if you're male and you go to high altitude, if you develop Cheyne-Stokes, it protects you from cerebral edema. So Cheyne-Stokes is a mechanism the body produces in some circumstances, and it may be at least partially adaptive. What else is new? CAT-HF was presented in Florence about 2 weeks ago, just the top-line results here, and this is about patients with acute decompensated heart failure with central sleep apnea. It was stopped as CERV produced its results, obviously. We thought it was unethical to continue it, and there really was no evidence of benefit in that group either, except for this. Now bear in mind, it's a subgroup analysis of a trial that was stopped early, so there's not a lot of power, but even with that, you can see that the preserved ejection fraction patients seem to have a very different point estimate, which is on the other side of the line. So perhaps hope for the future, maybe HFpEF is something that you can change its natural history by treating the comorbidity. ADVENT-HF, you want more evidence? Well, a trial is still going on by Doug Bradley's group, and this is both OSA or central sleep apnea in systolic heart failure. Now, I suspect the central sleep apnea patients are not that enthusiastic about going into the trial now, but OSA and heart failure still do. So let's hope they come out with some results in the near future to help us with that question. So, I was asked, sleep apnea and heart failure, what should we do? Well, in summary, just the take-home message from here, don't reach for airway pressure therapies at the moment for central sleep apnea in heart failure with systolic dysfunction. If a patient is already on that, you will probably have to counsel them about risks and benefits with that therapy. This is a big shock, particularly to sleep physicians. Never for a second did anybody think, neither did I think, that actually getting rid of a marker of high risk and a very abnormal physiology would make things work. I think there is one group of patients where you really do have to think about it on an individual basis, and that is somebody with very high daytime somnolence and good going obstructive sleep apnea. We don't have randomized trial evidences yet, but the therapeutic imperative might be to keep them safe and to improve their quality of life. In that case, I think it's a question you take case by case. Thank you very much indeed.